we are having two presentations. One is going to be by Vuthlarhi and then the other one by Dr. Kudzai, and they are going to be basically centered around gender-based violence. So just keep yourself muted, and for the presentation, if you have any question, you might want to drop them in the comment section, and at the end of the two presentations, we are going to take questions for the presenters. So I'm going to give the floor to Vuthlarhi, who is going to give a brief intro of herself and then start her presentation. Thank you.
All right, thank you so much, Ivan. I'm just going to be sharing my screen. Okay, and can everyone see my screen?
Yes.
All right. So good afternoon, everyone. My name is Vuthlarhi Shirindza. I'm a final year medical student as well as a global surgery RAI fellow. And today I'll be presenting an overview of gender-based violence. So before we begin our presentation, I'd just like to issue a trigger warning. So this presentation contains information and discussion on gender-based violence, which may be distressing or triggering to some individuals. So if at any point you do feel overwhelmed or need support, please reach out to a trusted friend, a family member, or a mental health professional. And at the Faculty of Health Sciences, we have Ms. Nonkosi Malala, who is always available. All right. So gender-based violence refers to any type of harm that is perpetrated against a person or group of people because of their factual or perceived sex, gender, sexual orientation, or gender identity. So gender-based violence affects individuals of all genders, but it disproportionately affects women and girls. Women and girls are likely to experience GVB, particularly in the form of intimate partner violence and sexual violence. LGBTQ plus individuals are also at an increased risk of experiencing gender-based violence, and this is particularly for trans and gender non-conforming individuals. Men and boys can also experience GBV, although it may be underreported due to social norms and stigma that surrounds male victims. So gender-based violence can include sexual, physical, mental, and economic harm that's inflicted either in public or in private. So it includes threats of violence, coercion, and manipulation. And this can take many forms, such as intimate partner violence, sexual violence, child marriage, female genital mutilation, as well as honor crimes. But GBV is rooted in inequality and power dynamics. It's often used as a means of exerting power and control over individuals, particularly women and girls, in order to maintain these unequal gender norms and structures. So let's just have a look at some of the misconceptions around GBV. One common misconception is that only financially dependent women are abused. But the fact is that GBV can happen to anyone, regardless of their socioeconomic status. Abusers use various forms of power and control to maintain dominance over their victims. And financial abuse is just one of those tactics that are used. Women who are financially independent can still be subjected to emotional, physical, and sexual abuse. So it's important to recognize that GBV is not caused by a personal characteristic or even a behavior of the victim, but rather by the abuser's desire to maintain power and control over their partner. Another misconception is that intimate partner violence always presents with physical evidence. The fact is that intimate partner violence is mostly a psychological crime. So research has shown that intimate partner violence is primarily a psychological crime, with emotional abuse being a constant and common and significant component. So psychological abuse can take on many forms, and this includes verbal and emotional attacks. It could be threats, isolation, control, and manipulation. So these behaviors can have significant impacts on the victim's mental health, their self-esteem, as well as their overall well-being. But unlike physical violence, which may leave visible marks or bruises, psychological abuse is often invisible, which makes it more difficult to detect as well as to seek help. So gender-based violence is a pervasive problem globally. with an estimated 1 in 3 women who experience physical or sexual violence in their lifetime. GBV can occur in any setting and can have serious and long-lasting physical, emotional, and social impacts. And the United Nations has reported that in some countries, up to 70% of women experience physical or sexual violence from an intimate partner in their lifetime. Taking a closer look at GBV in Africa, South Africa has one of the highest rates of GBV in the world, with an estimated 51% of women having experienced some form of violence in their lifetime. The Democratic Republic of Congo has been described as one of the worst places in the world to be a woman, with extremely high rates of sexual violence and other forms of gender-based violence. So more than 40% of women and girls in the DRC have experienced physical violence, and more than 20% have experienced sexual violence. So these numbers are likely to be underestimated due to underreporting, stigma, as well as fear of reprisals. And what makes it worse is that the ongoing conflict and displacement in the country have also contributed to the prevalence of gender-based violence. Nigeria has high rates of sexual and gender-based violence, particularly in conflict-affected areas in the northeast of the country. However, according to a 2014 national survey that was conducted by the Nigerian government and United Nations Women, only 28% of women in Nigeria have experienced physical violence and 14% have experienced sexual violence. However, this might also be due to the underreporting in the country because of stigma and cultural norms. In Kenya, gender-based violence is a significant problem with high rates of intimate partner violence, rape, and sexual harassment. According to a national survey that was conducted in 2014, 45% of women and 45% of men who are aged between 15 and 49 years have experienced either physical or sexual violence or both at some point in their lives. Additionally, 14% of women and 6% of men reported experiencing sexual violence in their lifetime. It's important to note that these stats may not fully capture the extent of gender-based violence in Kenya, as many cases go unreported due to social stigma, fear of reprisals, as well as lack of trust in the justice system. Gender-based violence in Egypt is widespread, with high rates of sexual harassment, rape, and domestic violence. According to a UN survey in 2013, 99% of women in Egypt reported experiencing some form of sexual harassment. So it's important to note that these are not the only countries in Africa with high rates of gender-based violence, and the situation can vary within each country depending on factors such as geography, culture, and socioeconomic status. Having a look at gender-based violence in South Africa, South Africa has one of the highest rates of gender-based violence in the world, as I've mentioned, with women and girls who are particularly at high risk of experiencing violence and abuse. So we have a quadruple burden of disease in South Africa, which consists of chronic diseases, HIV and AIDS, and as well as TB, maternal and child health, and violence and injury. So of all the violence in South Africa, research has shown that 38% is interpersonal violence and 62% is intimate partner violence. According to statistics, a woman is killed every 3 hours in South Africa, and more than 40% of women have experienced physical or sexual violence in their lifetime. South Africa has one of the highest femicide rates in the world, where femicide is the killing of girls. And the high prevalence of gender-based violence in South Africa can be attributed to a range of factors, including patriarchal attitudes, gender inequalities, and a history of violence and oppression. So the South African government has implemented a number of policies and programs that are aimed at addressing gender-based violence, such as the National Policy Framework on GBV and the National Council on GBV. We have a range of services that are available to victims of gender-based violence, which range from healthcare services, legal services, and support services, such as counseling and shelters. The healthcare system provides a range of services to victims of gender-based violence, including emergency medical treatment, forensic examinations, post-exposure prophylaxis for HIV, as well as for other sexually transmitted infections. And these can be accessed at hospitals, clinics, as well as other healthcare facilities across the country. Thuthuzela Care Centers are a one-stop facility that have been introduced as a critical part of South Africa's anti-rape strategy, which is aimed at reducing secondary victimization and to build a case that's ready for successful prosecution. Since being established in 2006, the country currently has 51 centers that are spread throughout the country. So you can report a case directly to the TCC, the Thuthuzela Care Center, and this TCC is usually based at a community clinic or a hospital, or you can go directly to a police station, and the TCC staff will assist you to get immediate medical attention at the center. They will also assist you to arrange counseling service at the center. They'll assist you to open a case if you want to do so immediately or even at a later stage. Or they can even arrange for ongoing counseling and prepare your case for court if the case does decide to go on trial. So survivors of gender-based violence can also access legal services throughout the South African justice system. And this includes obtaining a protection order, filing criminal charges against the perpetrator, and accessing legal representation. These services can help survivors to obtain justice and hold perpetrators accountable for their actions. In terms of support services that are available, these range from NGOs, counseling, and shelters. So some notable NGOs are like Rape Crisis Cape Town, People Opposing Women Abuse, Sonke Gender Justice, just to name a few. In South Africa, we also have pastoral care, which plays an important role in addressing gender-based violence. And this is particularly in communities where religion and faith play a significant role. So many religious leaders and faith-based organizations have recognized the importance of addressing gender-based violence and have taken steps to provide support and assistance to the victims. However, it's important to note that not all victims of gender-based violence may be comfortable seeking pastoral care services, particularly if the violence they've experienced is related to their religion or faith. So it's important for all support services, including pastoral care, to be sensitive to the unique needs and experiences of gender-based violence victims and to provide services that are non-judgmental, confidential, and respectful of their beliefs and cultural practices. So community-based organizations, community leaders, and other stakeholders also play a crucial role in addressing awareness about gender-based violence. And this is by providing support to survivors as well as advocating for policy changes to prevent and respond to gender-based violence. So community care centers for gender-based violence include counseling and support services, advocacy and awareness raising, as well as referral to healthcare and legal services. So community care centers are more accessible and culturally appropriate than other formal services such as healthcare services and legal services. And they can play a crucial role in supporting survivors of gender-based violence in South Africa. But some of the cons to these pastoral and community care services is that they use a faith and community and culture-based approach. Throughout this process, women are often encouraged to persevere in the abusive relationship. There's a lot of disempowerment of women, and most times the abuse is perpetuated. The community can also decide to take the justice into their own hands, and thus resort to mob justice, which is also not beneficial for the community. So it's difficult to determine which support services are most preferred by gender-based violence victims, as individual preferences can vary depending on cultural, social, and personal factors. But despite the availability of services, there are still significant barriers to accessing them. Some of these include stigma and shame that can prevent survivors from seeking help. Financial barriers can also be a major obstacle. The lack of knowledge about available services, as well as the lack of available services themselves, can hinder people from seeking help. Um, another Another one is fear of retaliation, as well as cultural and social norms that discourage seeking help outside of the family or the community. And a big barrier to care is secondary victimization that happens at these services, particularly at legal services such as the South African police services. So in conclusion, Gender-based violence is a pervasive problem globally, and particularly in Africa and South Africa. It's a violation of human rights that affects individuals of all genders, but it disproportionately affects women and girls. So while South Africa has a range of services that are available to survivors, there are still significant barriers to accessing these services. It's important to address the underlying social, cultural, and systemic factors that contribute to gender-based violence in order to prevent and respond to it appropriately. So this requires a comprehensive approach, which includes legal and policy reforms, education, and awareness raising, as well as the promotion of gender equality and women's empowerment. So as Ban Ki-moon said, gender-based violence is not inevitable. It can be prevented and it must be prevented. Thank you so much. Here are some of the resources that I used. And does anyone have any questions?
Thank you very much for your amazing presentation. So I think we are going to take the questions at the end of both presentations. So I'm going to give the floor to Dr. Kudzai to give us his presentation. Thank you.
One. Hello?
Yes, Dr. Kudzai, you can go on.
Yes, can you see my screen?
Yes, we can see your screen.
I think go to start.
Down.
Perfect.
There.
Hi.
Lovely.
Right, so my name is Dr. Kudzai Chironga. I'm an orthopedic trauma research fellow attached to orthopedics as well as global surgery. So my presentation is going to be on fractures in gender-based violence. It's a fairly a short presentation because this is one area that has not been studied very well. Most of the studies concerning gender-based violence have been extensively done in obstetrics and gynecology as well as emergency medicine, but not necessarily in the realm of orthopedics. So this is something new that the orthopedic fraternity is actually looking into. So some of these definitions have actually been alluded to by Vuthlarhi. So according to who, domestic violence is any behavior of a partner or ex-partner that causes physical, sexual, psychological harm, and it includes physical aggression, sexual coercion, psychological abuse, and any form of controlling behaviors. So as previously mentioned, globally, 1 in 3 women have experienced IPV, but I also came across some literature that also talked about men. It was only one article that did mention it because I think for men, it's something that is underreported, and because of social norms, men do not necessarily divulge such information easily. But it did say for every 1 in 6 men, they have also experienced some form of IPV, but I still believe that is underreported. The long-term effects that are associated with IPV can be things like headaches, gastrointestinal disorders, and fibromyalgia. So some of the additional effects may include depression, eating disorders. Then there's also illicit alcohol and drug abuse, and in some cases, suicidal ideation as well as attempts. So within the orthopedic realm, there is a procedure of research that focuses on intimate partner violence. But the current literature that I came across has identified a lot of gaps, both in the knowledge and research of IPV within orthopedic surgery. But it has been noted that approximately a third of injured women who present to the fracture clinics have experienced some form of IPV in the past year. And mind you, that's almost the same prevalence of IPV worldwide, that a third of women have been subjected to IPV. So the American Academic Orthopaedic Association's Canadian Orthopaedic Association have acknowledged the importance of recognizing intimate partner violence as a substantial problem among patients with musculoskeletal injuries. And there's a landmark study, the PRAISE study, which looked into intimate partner violence, and they enrolled about 2,945 women. And what they were looking at, orthopedic, about 80 orthopedic fracture clinics that were in Canada, United States, as well as India. And they showed that 1 in 6 women that presented in an orthopedic fracture clinic had a history of abuse within the year. And of those patients that attended that clinic, 1 in 50, which is about 2% of those who are attending that appointment, had a direct injury that was as a result of the intimate partner violence. And of those injuries, 80% of them were fractures that were treated. So apart from just fractures, you can also have sprains and dislocations. But apparently of those 2%, 80% were actually fractures. It's also important to note that musculoskeletal injuries come second to head and neck injuries, and they are present in these musculoskeletal injuries are actually present in up to 42% of victims of domestic violence. So this is a picture that I got from one article, a review article that was done in the United States. It was over an 8-year period, and what they did is they looked at their trauma registry, and what they did, they had a specific code that depicted intimate partner violence. So they entered that code, and they were looking specifically for patients who had musculoskeletal injuries. And what they did is they came up with this mapping of the patient's body to see which are the most common injuries that are associated with intimate partner violence. So as you can see, they looked at about 1,300 1,300 cases were the ones that did fit into the inclusion criteria. So out of those 1,300 patients, you can almost see that head and neck injuries almost cover half of the injuries, with more injuries around the nasal area, followed by the mandible, as well as the orbital region and the malar region. The spine slightly on the lower range. It's also followed by thoracic spine injury, lumbar spine injuries, and injuries of the forearm, and less with the phalanges, but the number is quite high. Then you also have injuries that are involving the lower limb, the tibia, the fibula, and around the ankle. Some literature does say the common injuries that patients do have are foot injuries, but according to this particular article, the foot bones were not really affected. And in some cases, they talk of hand injuries, but as you can see on this graph, more of the radius and ulna is involved compared to the hand. But of particular importance is in the forearm. What is usually fractured is the ulna, because it comes out as a more of a defense fracture as patients try to block off when they are being struck by a perpetrator. As you can see, ribs are also an issue. This is because when they are lying defenseless on the floor, they get kicked multiple times by the perpetrator, and they can either be struck by a blunt object, resulting in ulnar defense fractures. So, especially when you see ulnar defense fractures, they are fractures that are considered pathognomonic of gender-based violence. But in essence, the patients never divulge that information ready. So musculoskeletal injuries are mainly in the upper limbs and trunks are the second most prevalent type of injury after the head and neck injuries, as I previously explained. And most frequently, the mechanism of injury is blunt trauma, and they account for up to about 70% of the injuries. So we should also note that intimate partner violence injuries do not necessarily occur in isolation. They are generally accompanied by other injuries, in different parts of the body or within the same region, and they can also be at different stages of healing. Some that would have completely healed from previous injuries. So knowing the typical fracture patterns or locations is helpful to identify IPV patients, especially when the victim may not fully divulge the history and details of the event. Trauma at the upper limbs, especially fingers, forearms, particularly the ulna into the ribs, should always be suspected as arising from IPV. Therefore, a high level of suspicion is necessary to allow orthopedic surgeons to perform complementary examinations or imaging interventions that enable the detection of victims of IPV. It is important to know that early detection of abuse is important to prevent more serious injuries and consequences that can occur, which may include mutilation and death. So the role of an orthopedic surgeon who works in the front lines of an emergency care is very fundamental. And because we have demonstrated a high prevalence of IPV among patients that are presenting in our fracture clinics, it suggests that the fracture clinics are very an opportune setting for offering support to IPV victims. So there's a reason to believe that patients in orthopedic clinics may experience more severe IPV than other patients. And this is mainly because most of the patients that do have intimate partner violence, they have injuries that we can pick up, but they are not necessarily fractures. So the argument is, once a patient is a victim of IPV and actually has a fracture as a result of IPV, it is considered more of a severe injury. And so that's why it's now becoming important for orthopedics to be aware of this issue of intimate partner violence. So these are the references that I used for my research. There wasn't much in terms of fractures, but a lot of information is out there concerning intimate partner violence, as you can see from the presentation that was done by the previous speaker. But if there are any questions, I'm happy to answer them.
Thank you very much, Dr. Kudzai, for the amazing presentation. So if I can summarize what I'm taking out of this presentation from from Vuthlarhi and Dr. Kudzai is that all genders are affected by gender-based violence, and GBV can be verbal, physical, psychological abuse, and it is a form of a silent pandemic, and the sensitivity requires well-coordinated and also multi-sectoral interventions, and all stakeholders susceptible to help need to be involved in addressing this issue. And in the orthopedic realm, some injuries can make the healthcare provider suspicious of a possible intimate partner violence. So, as my own question, before I give the floor to the rest of the panelists, the people in the crowd. So my first question, the question I have for Vuthlarhi is, during your presentation, during your research, did you come across interventions developed to sensitize families on the GBV, and what do you think of the interventions focused on families to help reduce the burden of this silent pandemic? Thank you.
Thank you so much for your question, Ivan. In terms of the work that's being done to sensitize families, particularly, I don't think a lot is being done. I think a lot of the services right now are focused on women empowerment, either a community-based approach or it's a victim-based approach. So, example, if the victim has undergone some abuse, they'll usually go to an NGO and a shelter, and then there'll be support from that angle. But from a community-based approach, the NGOs and the shelters and community healthcare workers are going in those areas and informing women that, gender-based violence is prevalent in the community, and this is what you should do if you are being abused. So from a family point of view, in terms of like focusing on all members of the family, particularly the men and the boys who do usually perpetrate the abuse, I haven't come across a lot of research or a lot of NGOs that are focused on them, or even if they are, it would, for example, be focused in a single area. So you'd have an NGO that's working in Cape Town, for example, and they're offering their services to a particular community, like in Khayelitsha, but these similar services aren't available in like Johannesburg or Mpumalanga or Limpopo. So a lot of the work that's currently being done right now is either victim-based, which is like, where we're treating families, or um, it's very community-based, but not a lot of work that's like widespread throughout the community, accessible for all people and like all communities. So it's really dependent on the position that you hold in the family, as well as where you are geographically in terms of the access, the services that are available to you.
Yeah, thank you so much. And Dr. Kudzai, so in your department where you are currently working, are there specific interventions that are being put in place to assist the victims? If yes, what are they, please?
Like I previously mentioned at the beginning of the presentation, this is sort of like a new dimension within the orthopedic realm. And most of the literature that I came across is from Europe. So this hasn't been done in Africa from pretty much from the knowledge that I have. As far as I know, there's no research within the orthopedic fraternity within Africa, and let alone in South Africa, concerning IPV in orthopedics. So I had a paper that I'd been working on, just trying to look at the prevalence of orthopedic injuries that are associated with intimate partner violence. And there were a lot of concerns that I received from HVAC concerning that topic, because it's considered a very sensitive topic. So whilst I was working on that research, I also tried to look into whether there are measures that are there that are present in case you come across a victim of IPV within our clinics. So at the moment, I don't think it's robust enough. Like Vuthlarhi has just said, like there are these centers that are available, and the same centers that were mentioned, because the first port of call when you identify a patient with IPV from our unit is to inform the social worker. So when I spoke to the social worker, what she did say is they would receive the complaint from the individual, but it's up to the individual to report to the police. So what they'll do is they'll still advise the patient, they'll still counsel the patient. That's what they do as social workers. Then they advise the patient to report the case to the police. Only when the patient has reported the case to the police, then they can assist with the process thereafter. And that involves referring them to other support services that are within their home area. So for me, I felt it's probably inadequate, because some of the literature that came up, they did say they're trying to come up with sort of like a unit within the orthopedic field where they can deal with such victims. Because they gave an example of osteoporosis. I mean, long back, osteoporosis was never within the orthopedic realm. We would just see a patient with a fracture, even if it is a consequence of osteoporosis, we'll just refer the osteoporotic patient to the physicians to deal with the osteoporosis. Then we later on realized that the same patients with osteoporotic fractures, they still come back with another fracture in one patient. A few months or a year later, a different fracture. So at the end of the day, we ended up deciding to come up with a way to deal with osteoporotic patients, because we know that even though it's osteoporosis, but the complications are orthopedic, so we need to prevent more fractures. So what they're basically saying is we also need to come up with the same structure that was used for osteoporosis, to say if we don't deal with IPV or gender-based violence, we are still going to continue seeing these type of injuries from intimate partner violence. So we need to come up with a robust type of setup that when you do identify patients with IPV, You have an all-inclusive center that involves the social worker, that involves these other service providers, that involves the police, just in one place so that they can coordinate and see how best they can help with these victims. So at this stage, all we have is if you identify a victim, you report to the social worker, and the social worker will take it from there. But I can give you one example. Is I came across one patient as soon as I started working on this IPV project. I saw one or two patients that came into clinic. And it's funny is that I probably would have seen these things before, but I never picked it up. But this patient actually had the blue eye and the defense fracture. And in my head, because I was already working on this, it just opened up my eyes and I was like, what happened? She's like, she fell. I was like, but you fell, but what else happened? Then she said, no, I was beaten up by my partner. I said, but have you reported this to the police? I said, I'm not going to report the police because he's the breadwinner. But it's like, but do you know you have the right to report him? And that was the end of the conversation. It's a bit tough because now you know that something needs to be done, but at the same time, the victim also doesn't want to take up the case to the police. Then what do you do then? So I think those are the challenges that come into play, issues of stigma and all other things that were previously mentioned by the previous speaker. So it's a difficult kind of situation though. I hope that answers your question.
Yeah, definitely. Thank you so much with a lot of insight too. So I'm going to give the floor to Archie, who probably has a question or a comment. Archie, go on.
Thanks, and thank you to the two speakers. I think it's a very important topic. Yeah, I think Dr. Chironga covered some of the things I wanted to say. Look, currently in orthopedics, we do not have any interventions really that or protocols of how to deal with these patients, because previously we were not looking for these patients. We just completed a study now over 12 months, and we just looked at the injury patterns, and we identified those who came with IPV and what was the injury patterns, and we managed to identify 33 patients. And since then, we started actively looking for them. Well, we haven't published a study, just finished it now, but we started actively looking for them, and we see more and more and more of them. But there are no protocols of how to identify these patients, and how to deal with them once you have identified them. Our protocol is similar to what they're using at Kudzai, which we refer to the social worker and the psychologist. I'm not sure if that's really a solution, because we also see repeat offenders. You refer them there, but they still go back to the same environment, and then they come back with the same injuries. And this is not only females, even in males. We had recently had a male patient who has been admitted in our ward 3 times with severe injuries, and every single time he was assaulted by the girlfriend. But he is more of dependent on the girlfriend. Is unemployed, so he does not want to open a case or anything because he's dependent on the girlfriend, but it keeps happening. We also had a couple that they were admitted in separate ward at the same time because they were fighting, and they both had their injuries. So these injuries are common, especially in orthopedics. We started actively screening them. Every patient that comes with the injury, we want to know what is the mechanism of injury, how actually it happened about, and most of them is IPV. I wrote a review paper for the current journal last year, trying to highlight this problem and that we don't have a local, or we don't have a means of dealing with this, but the journal was rejected. So yeah, but yeah, that's all I wanted to say.
Thank you so much, Archie. They are amazing insight, and I think maybe with a lot of advocacy from a lot of centers, maybe we are going to succeed in attracting the attention of stakeholders to definitely have a look into it. Dr. Kudzai, you have something to say?
And it's actually me, Moses, not
All
I'm
right,
in the
Moses,
office with you. Yeah, so I think this goes to Archie and him. The thing is, if we are saying that we have about 51% of females that actually are affected by gender-based violence, and majority of them end up in the faith-based centers. My question is, do we have to put the Baruti and pastors to task, because most of this is actually hidden in the church in the name of Jesus and praying in tongues? Is there a place for us to actually either capacitate them to be able to report such cases to the police, or it's still very sensitive as a topic?
Look, I think you have a point. This has to be a multidisciplinary team approach, and in the multidisciplinary team approach, this has to involve the community as well. And the community leaders mostly is the church leaders, which are very important people in this. So we should not blaming them, but we should be involving them in the management of these patients.
Thank you.
I think one other thing I think that I came across is the challenge with the faith-based approach is these are the first sort of like people where victims go to, because that's where they are more comfortable. And some of this year actually says the reason why they don't go to the police or to other formal service providers is because sometimes the injuries that they have, they are not considered significant. But once they start having serious injuries like fractures or like head injury, that's when they usually report to the formal sector. Community leaders and pastors are more put in the informal sector, but that is usually where the patients go to. The only problem with the pastors that was highlighted is they have a faith-based approach, which is to preserve the marriage and preserve the family. So in that case, they always sometimes end up including the perpetrator into their discussions, and they don't realize the magnitude of doing that and the risk that they are putting the victim into, because their approach is to save the marriage and to save the family. But then the moment they bring in the perpetrator into the picture, according to the perpetrator, he has already been reported to. So that also puts the victim at risk. And the other thing is the pastors don't have the knowledge of the other consequences of IPV, which include post-traumatic distress disorders, the eating disorders that we're talking about, the risk of suicidal attempts. Those are things that come in the long run when the pastor is already out of the picture. So what's important is, because they are also integral in dealing with IPV cases, there's also some importance in trying to see if they can be trained on how to deal with IPV cases, apart from their religious support, but they should be equipped with knowledge on how to deal with IPV, how to handle those patients, knowing that in as much as they want to preserve the marriage, but they should be aware of the risk of trying to involve the perpetrator in those discussions. So training, I think, is important, but how to execute that training is another story.
Thank you so much. Yeah, somebody has something to say? Okay, no one. So thank you definitely for all the comments and the amazing insight. So if there is no other comment or question, I think we are going to end today's academic meeting. Thank you again for coming, and hope to see you in the next meeting. Bye.
Thank you, Ivan. Bye.